Hello everybody. Today we are going to discuss about ventilator graphics. So graphics are the waveform that reflects the patient ventilatory system and their interpretation. Purpose of monitoring graphics are it allows the user to interpret, evaluate and troubleshoot the ventilator and the patient's response to the ventilator. So monitor the patient's disease status and assess the patient's response to the therapy. It monitors the proper ventilator function. Allow the fine tuning of the ventilator to decrease work breathing, optimize ventilation, and maximize the patient comfort. So these are the types of the ventilator. So first one is scalar. Scalar is the plot pressure, volume, or a flow against the time. Time is x-axis here. Then the loops is the plot pressure of the flow against the volume, and there is no time component. So these are the types of the waveform. Basic shapes of the waveform are square waveform, ascending ramp waveform, descending ramp, sine waveform, exponential rising, and the exponential decay. So basic shapes of waveform in square wave. It represents the constant or the set parameter. For example, pressure setting in the pressure control mode or flow rate setting in the volume control mode. Then the ramp use. It represents the variable parameter and it will carry with the changes in the lung characteristic. It can be accelerating or decelerating. Then sine wave, seen with the spontaneous and the unsupported breathing. So volume mode, the waveform will be like this. So there won't be any plateau, but the pressure waveform will be the ascending. In pressure mode, the pressure waveform will be the square shape. Now let's in volume mode, the shape of the pressure wave will be ramp for the mandatory breaths. As I mentioned before, in pressure modes, the shape of the pressure wave will be square shape. This means that the pressure is constant during inspiration or the pressure is set parameter. In volume mode, adding the pause will add small plateau to the wave. This thought to improve the distribution of the ventilation. Now, the pressure waveform can be used to assess air trapping, airway obstruction, bronchodilator response, respiratory mechanics, active exhalation, breath type, then pressure inspirator, P-flat, peak inspiratory pressure, P-flat, CPAP, PEEP, asynchrony, and the triggering effect. So the pressure waveform is the baseline for the pressure waveform will be higher when PEEP is added. And there will be the negative deflection just before the waveform with the patient trigger the breath. Now the pressure waveform is represented like this. So the number one is the peak inspiratory pressure. Number two is the plateau pressure. A is airway resistance and the B is alveolar distending pressure. Now the type diagram A is representative of the increased airway resistance causing the peak inspiratory pressure to increase, but P-flat remains normal. Then diagram B is representative of decrease in the lung compliance causes the entire waveform to increase in the size. So the difference in the peak and the P-flat is the airway resistance. So the pressure waveform while performing the expiratory hold maneuver, the trapped air will cause waveform to rise above the baseline. An acceptable amount of the auto peep is always less than 5. Now, this is the same component of the pressure waveform where one is representative of the peak inspiratory pressure, two is representative of the plateau pressure, then A is airway resistance, and the B is alveolar distending pressure. Now about volume waveform. Volume waveform will generally have mountain peak appearance at the top and it may also have the plateau or flattened area at the peak of the wave. There will be the plateau if inspiratory pause time is set or inspiratory hold maneuver is applied to the breath. Now the volume waveform can be used to assess air trapping, leak, tidal volume, active exhalation and async. So this is the representation of the volume waveform where orange color part is representative of the inspirated tidal volume and the pink color part is representative of the exhaled volume returned to the baseline. So a volume waveform is this is the diagram of the volume waveform suggestive of the airway trapping or the leak. If exhalation side of the waveform doesn't return to the baseline, it could be from the airway trapping, or there could be the leak. Then flow waveform. In the volume mode, the shape of the flow will be the square. This means that the flow remains constant or the flow rate is set parameter. Then in pressure waveform, the shape of the flow waveform will have ramp pattern. So, flow waveform can be used to assess airway trapping, airway obstruction, bronchodilator response, active exhalation, breath type, inspiratory flow, asynchrony, and triggering event. So this is the two waveform. So number one diagram is representative of the flow waveform in the volume mode, and in pressure mode, the number two is representative of the flow waveform in the pressure. So the decelerating flow pattern may be preferred over the constant flow pattern. The same tidal volume can be delivered, but with the low peak pressure. So in auto peak, if the expiratory portion of the waveform doesn't return to the baseline before the start of the next breath, there could be the air trap. Now, to assess the response of the bronchodilator therapy, you should be seeing an increase in the peak expiratory flow rate. The expiratory portion of the curve should return to the baseline soon. So this is the type of the waveform. Again, the diagram 1 is representative of the volume waveform. The diagram 2 is representative of the pressure. In pressure limited control mode, the inspiratory flow should return to the baseline. In support mode, the flow doesn't return to the baseline. So as we can see here, the flow is returned to the baseline. That means it is the control mode. But in support mode, the flow won't return to the baseline, as we can see here. So by this, we can understand if this pressure support is in the control mode or in the support. The area of the no flow indicated by the red line, and it is also known as the zero flow state. It indicates the inspiratory time is too long for this patient. So again, this is the pressure mode, which is the square, which is representative by this square waveform, and the volume mode represented by the ramp pattern. Now the next is pressure volume loop. Pressure volume loop. The volume is plotted on the y-axis and the pressure on the x-axis. Inspiratory curve and expiratory curve is down. Spontaneous breath go clockwise and the positive pressure breath go counterclockwise. The bottom of the loop will be at the set peak level. It will be at 0 if there is no peak set. If the imaginary line is drawn down the middle of the loop, the area to the right represents the inspiratory resistance and the area to the left represents the expiratory resistance. Now it can be used to assess lung over distension, airway obstruction, bronchodilator response, respiratory mechanics, work of breathing, flow starvation, leaks, and the triggering effort. So this is the pressure volume curve. The top of the this is the expiration and uh, the inspiration. So again, this is the pressure volume curve. This almost becomes square shape in the pressure mode because of the pressure limit. Now again, this is the pressure volume curve. The pressure continues to increase with the little or no change in the volume, creating bird beak. It is fixed by reducing the amount of the total volume delivered. Now this is again the pressure volume curve suggestive of the airway resistance. And airway resistance increases, the loop become wider, and increase in the expiratory resistance is more commonly seen. So expiratory resistance is seen by it's represented by the sky blue color, and the pink color is representative of the increase in inspiratory resistance. The causes in expiratory resistance is secretion and bronchospasm, and the causes of increased inspiratory resistance is kink tube and the patient biting tube. Increase compliance. This first pressure volume loop is suggestive of the increased compliance, and it is seen in emphysema and surfactant therapy. The other diagram is representative of the decreased compliance seen in ARDS, CHF, and atelectasis. The expiratory portion of the loop doesn't return to the baseline. This indicates the leak. Now, this is the pressure volume loop suggestive of the inflection point. The lower inflection point represents the point of the alveolar opening, and some lung protection strategies for treating ARDS suggest the setting peak just above the lower inflection point. Now, this is the flow volume loop. Flow volume loop, the flow is plotted on the y-axis and the volume is on the x-axis. The flow volume loop used for the ventilator graphics are same as one for the pulmonary function test. Inspiration is above the horizontal line and the expiration is below. The shape of the inspiratory portion of the curve will match the flow wave. The shape of the expiratory flow curve represents the passive exhalation, and it can be used to determine the peak inspiratory flow, peak expiratory flow, and tidal wave. It looks circular with the spontaneous breath. So it can be used to assess airway trapping, airway obstruction, airway resistance, bronchodilator response, inspiratory expiratory flow, flow starvation, leak, water or secretion accumulation, and asynchro. So the flow volume loop, which representative of the beginning of the inspiration and beginning of the expiration. So this is the shape of the inspiratory portion of the curve will match the flow waveform. So this is again the flow volume loop with the L. If there is a leak, the loop will not meet the starting point where inhalation starts and the exhalation it. It can also occur in the airway trap. As we can see, the expiratory part of the loop. So as we can see here, this expiratory part of the loop doesn't return to the starting point, indicating a leak. This one. So the next is flow volume loop suggestive of the airway obstruction. The expiratory part of the curve scooped with the disease, as we can see in this diagram. So this is the scooping. So this is the expiratory part. The expiratory part of the curve scooped with the disease that cause the that causes the small airway obstruction. Now this is again the flow volume curve, which is showing the airway obstruction. In this, FV loop appears upside down on the most ventilator. Again, there is a scooping on the expiratory part. Now the next is airway trapping. That is autopsy. So causes are insufficient expiratory time and the early collapse of the unstable airway or airways during exhalation. Now, how to identify it on graphics in pressure wave on performing expiratory hold, the waveform will rise above the baseline. The flow wave, the expiratory flow doesn't return to the baseline before next breath begins. Then volume wave, the expiratory portion doesn't return to the baseline, and in the flow or volume loop, the loop doesn't meet at baseline. Pressure and the volume loop, the loop doesn't meet at baseline. Now, how to fix? Give the treatment, adjust the inspirated time, increase flow, and add peak. Now, airway resistance changes. It causes bronchospasm, ETT problem, high flow, secretion built up, damp or valve or filter, and the water in the HM. Now, how to identify the pressure wave? Peak expiratory, inspiratory pressure increases, but the plateau pressure stays the same. In the flow wave, it takes longer for the expiratory side to reach baseline and expiratory flow is reduced. In the volume wave, it takes longer for the expiratory curve to reach the baseline. Pressure volume loop. The loop will be wider. Increased inspiratory resistance will cause it to bulge on the right, and the expiratory resistance bulges to the left. Flow volume loop, it decreases the expiratory flow with scoop in the next curve. Now, how to fix it? Give a treatment, suction the patient, drain water, change the HME, change the ETT, bite block, reduce the PF rate, and change this filter. Now, compliance change. Decrease in the compliance causes are ARDS, atelectasis, abdominal distension, congestive heart failure, consolidation, fibrosis, hyperinflation, pneumothorax, and pleural effusion. Increased compliance is caused because of the emphysema surfactant therapy. If there is decrease in the compliance, then how to identify it on the graphic? If there is pressure waveform, the peak inspiratory pressure and the plateau both will increase. In pressure volume loop, it will lay more on the horizontal. If there is increased compliance, then the peak inspiratory pressure and the plateau both will decrease, and the pressure volume curve, loop will stand more vertical. The leak causes are expiratory leak, ETT cuff leak, chest tube leak, bronchopulmonary fistula, and the nasogastric tube in the trachea. Inspiratory leak, loose connection, ventilatory malfunction, and the faulty flow sensor. How to identify it? Pressure waveform, decrease the peak inspiratory pressure. Volume wave, expiratory side of the wave doesn't return to the baseline. Flow wave, peak expiratory flow will decrease. Pressure volume loop, expiratory side doesn't return to the baseline. Flow volume loop, expiratory side doesn't return to the baseline. Now, how to fix it? Check possible causes and do leak test and make sure all the connections are tight. Then asynchrony, neurological injury and improperty set sensitivity. How to identify it? Pressure waveform. The patient tries to inhale and exhale in the middle of the waveform, causing dip in the pressure. Flow wave. Patient tries to inhale, exhale in the middle of the waveform, causing erratic flow and dips in the waveform. Pressure volume loop. Patient makes the effort to breathe, causing dips in the loop, either inspiration and expiration. Then flow volume loop. Patient makes the effort to breathe, causing dips in the loop, either inspiration and expiration. Now, how to fix it? Try increasing the flow rate, decreasing the inspirated time, increasing the set rate to capture the patient. Change the mode, sometimes changing from the partial to full solve the problem. If neurologically, may need paralytic or sedative and adjust the sensitivity. So, asynchrony flow inspiratory portion of the pressure waveform shows the dip due to inadequate flow, as we can see in the diagram. Asynchrony flow volume loop flow volume loop is will look like this, as you can see in the first diagram. Second diagram, the pressure volume loop asynchrony will be presented like this. Now about rise time, the inspiratory rise time determines the amount of the time it takes to reach the desired airway pressure or the peak flow rate. Now about rise time, if rise time is too fast, so you can get overshoot in the pressure wave, creating the pressure spike. And if this occur, you need to increase the rise time. This makes the flow valve open a bit more slowly. If rise time is too slow, the pressure wave become rounded or slanted when it should be more square. This will decrease the tidal volume delivery or may not meet the patient's inspiratory demand. If this occurs, you will need to decrease the rise time to open the valve faster. Now, inspiratory cycle off. The inspiratory cycle off determines when the ventilator flow cycle from the inspiration to the expiration. In pressure support mode, it is also known as inspiratory flow termination, expiratory flow sensitivity, inspiratory flow cycle percentage, and the E cycle. So, inspiratory, the breath ends when the inspiratory flow has dropped to the specific flow value. So the above diagram is representative in the pressure mode, that inspiratory end of the inspiration. And in the flow form, the how it ends. So if in above example, means the what this diagram is suggestive of, the machine is set to cycle the inspiratory off at 30% of the patient peak inspiratory flow. So as we can see here, this part is representative of the 100% of the patient's inspiratory flow, and it is ending at the 30%. That means this machine is set to cycle inspiratory off at 30% of the patient's peak inspiratory flow. Now, inspiratory cycle off, as a diagram is representative of the cycle of percentage is too high and cycling off too soon. This makes the breath too small, not enough tidal, or it's not delivering enough tidal volume. Then the diagram B is representative of the cycle of percentage is too low, making the breath too long. This forces the patient to actively exhale, creating the exhalation. Thank you, guys.